All right, let's jump into this deep dive. Retinal vein occlusion. We're zeroing in on the central and branch RVO using those cases you marked in files 1 and 2 and, of course, good old textbook 3 as our roadmap. And to help us really dissect this, we've got our expert here to, well, make it all click. What I find so interesting about these cases is they really make you think on your feet, like you're right there in the exam room. Okay, so file 001 hits us with a pretty wild picture, right? A fundus photo with that classic blood and thunder look. We're talking tons of retinal hemorrhages, veins all dilated and twisty. It definitely grabs your attention. Now picture this. You're in the exam, this image pops up. What's running through your head?
Well, the hemorrhaging, it's just so severe. That's the first thing. That blood and thunder look, 9 times out of 10, it's screaming central retinal vein occlusion, CRVO. Basically, You've got a blockage in the central retinal vein causing blood to back up, and that leads to those lakes and the classic visual signs we see.
Okay, so you nailed it, CRVO. But file 001 takes it a step further, right? They ask about something specific on the fluorescein angiography, FFA. Blocked fluorescence. Why would we see that in a case like this one?
Okay, so to get that, we got to zoom in, think microscopic level. See those hemorrhages? They're actually the culprits here, blocking the fluorescent dye from reaching certain areas. Think of it like a garden hose with holes. You're trying to water, but it's not reaching all the plants evenly, right? Same idea here. The dye can't flow freely through all those hemorrhages, and boom, blocked fluorescence in the angiogram.
Gotcha. Okay, now put yourself in the exam room. Examiner's grilling you. What investigations do you order next? What's top priority?
Blood pressure and tonometry, those are my go-tos right off the bat. We have to rule out hypertension. I mean, it's a huge risk factor for CRVO. And tonometry, that's key for checking intraocular pressure, and here's why. Ischemic CRVO, it carries a pretty serious risk of neovascular glaucoma. Like, we're talking 60% risk here, not something to mess around with.
Neovascular glaucoma, yeah, that's a scary one. File 001 really drives home how important it is to catch it early.
Exactly, and that's why tonometry is so important. It's not just about diagnosing the occlusion. You're already thinking ahead, potential complications, how to manage them proactively.
Okay, let's switch gears a bit now. Management. What are our options for treating this patient? How does the textbook help us decide?
So textbook 3 really hammers this point. Treat macular edema. It's essential. That swelling in the central retina, it can really wreck vision. But the approach, the way we tackle it, hinges on one crucial thing. Is it ischemic CRVO or non-ischemic CRVO? That's the big question.
Ah, the million-dollar question. How can we tell them apart? And why does it matter so much for management?
Okay, so visually, ischemic CRVO tends to have that, more dramatic blood and thunder look like we talked about. Non-ischemic CRVO might have fewer hemorrhages, and importantly, you often see these collateral vessels on the FFA. Think of them like bypass routes they develop to keep some blood flowing.
And those collateral vessels, that's a good sign, right? Like the body's trying to compensate.
Exactly. They mean better perfusion, which usually means a better prognosis overall. Textbook image 13.28, it shows this perfectly. You see blocked fluorescence where the dye can't get through, but then bam, you see those collateral vessels lighting up. Some blood is still getting through.
So ischemic CRVO, bad blockage, poor perfusion. Non-ischemic, less severe, some perfusion, thanks to those collaterals. And this is what dictates how we manage it.
You got it. Ischemic CRVO, poor perfusion, it often needs a more aggressive approach. Think intravitreal injections of anti-VEGF medications to reduce swelling, prevent those abnormal blood vessels from forming, neovascularization, sometimes even surgery. Non-ischemic CRVO might respond to less invasive stuff, like laser therapy.
Makes sense. Before we jump to the next case, anything else from textbook 3 our listeners should absolutely know for their exam?
Risk factors, they're all over the textbook, and they're crucial. Age is a big one. After 50, the risk shoots up. Then you've got your usual suspects, hypertension, diabetes, glaucoma. It's all about understanding how these systemic things mess with the blood vessels in the eye.
So it's not just about memorizing a list, right? It's connecting the dots, those risk factors, and the why behind it all. And knowing these risk factors, it helps us educate patients, manage them long term, am I right?
Absolutely. If we can find those modifiable risk factors, address them, we can maybe prevent future episodes, protect their eye health overall. That's the goal.
All right, so we've covered a lot with CRVO, but what about when the blockage is more localized, like in branch retinal vein occlusion? File 002, it gives us a case that's really different from that dramatic picture in file 001. We got a 29-year-old guy, blurry vision in his left eye. Fundus photo shows hemorrhages, dilated veins, but it's not that widespread blood and thunder look we saw with ischemic CRVO.
Right, this one's way more subtle. What points us to BRVO? We'll see how the hemorrhages are just in one spot. They follow the path of a retinal vein branch, that localized pattern. That's a key difference between BRVO and CRVO. In this case, the blurry vision, it's probably from macular edema. That swelling in the central retina, the BRVO is causing it.
It's crazy how a blockage in just one spot can still mess with vision like that.
Absolutely, and that's why it's so important to understand the ins and outs of both CRVO and BRVO.
So how do we manage BRVO?
They suggest retinal laser photocoagulation. But there's a catch. It's usually done after those hemorrhages clear up.
Makes sense. Wouldn't want to zap an area that's still bleeding with a laser.
Exactly. Think of it this way. We're using this tiny, super focused laser beam, making little burns around the leaky vessels, sealing them off, no more leakage.
Like a microscopic welding torch. Fixing those leaky spots, reinforcing the walls.
Perfect analogy. Now, textbook 3, any other pearls of wisdom about managing BRVO?
Yeah, what does the textbook say about that?
It stresses that managing BRVO, it's not just about putting out the fire, you know? It's about understanding those long-term risks, the things that could go wrong down the line.
Like what kind of complications? What are we talking about with BRVO?
Well, macular ischemia, for one, where the macula is not getting enough blood. That can lead to permanent vision loss, no bueno. And then there's neovascularization, those abnormal blood vessels, more bleeding, more vision problems.
So just like CRVO, neovascularization is a big deal in BRVO too.
Yep. Shows how important it is to understand those shared pathways of damage, even though the initial problem and where it's blocked might look different.
And how does FFA help us figure out those potential complications?
FFA, it's a rock star for evaluating how bad the BRVO is, spotting those high-risk signs. For example, remember a vessel wall staining from textbook image 13.27? That's a classic sign we see on FFA with BRVO. It means those damaged blood vessels are leaking.
So even though BRVO might not be as dramatic as CRVO, it can still cause some serious problems if we don't manage it right.
You got it. And that's why we need to have a solid understanding of both conditions, the little differences between them, and what they could mean in the long run.
Okay, before we wrap up this whole deep dive, let's step back. Think big picture.
Yeah.
What are the key takeaways here? The things that'll really help our listener nail their oral exam?
I think the biggest thing is that first step. CRVO or BRVO, got to figure that out. Where's the blockage? How bad is it? Any collateral vessels on the FFA? How much hemorrhaging? All those clues, they tell us what's going on, and that shapes how we treat it. And don't forget those risk factors and what could go wrong later on. Shows the examiners you're thinking about the whole picture, not just the immediate problem.
Right. It's about showing them you really get it, the whole disease process, from the first signs to the long-term stuff.
You nailed it.
You know, I was just thinking that we've really dug into the technical stuff with CRVO and BRVO, but there's another piece to really mastering these cases for your exam, right?
Oh, for sure. I mean, you can know everything about, the science and the treatment, but if you can't actually talk to your patients about it, what's the point?
So true. Okay, imagine this. You're in that exam room, diagnosed CRVO or BRVO, and now you have to explain this to the patient.
Yeah.
Clearly, compassionately. Where do you even start?
Empathy. Always. Got to start with empathy. These are serious conditions. We're talking about their vision. People are going to be scared, overwhelmed. So first thing, acknowledge that. Let them know you get it. I might say something like, I know this is a lot to process, and you probably have tons of questions. We'll go through it all step by step.
Makes sense, starting with that human connection.
Totally. Then I use plain language, no medical jargon, to explain what's happening in their eye. Like, you have a blockage in one of the main blood vessels in your retina. That's the part at the back of your eye that senses light. This blockage is causing bleeding and swelling, which is why your vision is blurry.
No fancy words. Got it. But how do you explain something like ischemic versus non-ischemic to someone who's not a doctor?
Analogies, they're lifesavers. Seriously. For ischemic CRVO, I might say, imagine a huge traffic jam on a highway going into a city. The blockage is like that traffic jam backing up blood flow, so some parts of your retina aren't getting enough oxygen and nutrients.
I like that. Makes it easy to picture.
Right. What about non-ischemic? I might say. It's like there's a detour around that traffic jam, some blood is still getting through, that's a good thing. And then I'd talk about those collateral vessels, like those back roads that keep things moving.
Those analogies are great. Okay, what about treatment options? How do you explain those?
Keep it simple, always. For anti-VEGF injections, I'd say, these are medications we inject into your eye to reduce swelling and stop abnormal blood vessels from growing. You'll need them regularly, but they're really effective at protecting your vision.
What about laser therapy? Some people might be nervous about that.
Oh yeah, definitely. I always reassure them it's quick, painless. I describe it like using a really focused beam of light to seal off those leaky vessels, almost like a tiny welding torch fixing a leak in a pipe.
It's all about those comparisons, right? Making it relatable.
Exactly. And then we got to talk about the long term, what to expect. Patients are going to wonder about complications, what's going to happen down the line. I'm honest. I tell them we're doing everything we can, but there are risks with RVO. We talk about things like neovascular glaucoma, macular ischemia. But I also emphasize that with regular checkups and treatment, we can often manage those things effectively.
And that emotional support, that's huge too, right?
Absolutely. I make sure they have plenty of time to ask questions, share their concerns. I want them to know they're not in this alone. We're a team working together to protect their sight.
I think that sums it up perfectly. It's not just about knowing the facts. It's that human connection, being able to explain things in a way that makes sense and gives them hope.
Couldn't agree more. It's that blend of, the art and science of medicine. That's what makes it real for the patient.
Well, I think we've given our listener a lot to chew on today. We tackled those tough CRVO and BRVO cases, decoded those FFA findings, even got into how to talk to patients about it all. Hopefully you're feeling ready to crush those exams.
Fingers crossed.
Before we sign off, one last thing to think about, something we touched on earlier. We talked about those abnormal blood vessels in RVO. But what about the things going on in the body that influence angiogenesis, not just in the eye, but everywhere? It's a really interesting question. It links ophthalmology to this bigger picture of how the body works. Keep learning, keep those eyes healthy, and we'll see you next time on The Deep Dive.